Hi everyone, I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs Podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopaedic Society for Sports Medicine annual meeting in Washington, D.C.
The AOSSM annual meeting is the premier sports medicine conference each year, hosting over 3,500 attendees with hundreds of posters and paper presentations, exhibitors, and instructional course lectures. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 7 episodes, we're going to be exploring some of the hottest topics in sports medicine with these experts who are presenting at the AOSSM annual meeting.
We are supported by Stryker. Seeking a clinically proven solution for your patients with massive and irreparable rotator cuff tears that has the potential for early functional recovery and pain relief? Check out InSpace.
InSpace is the industry's only minimally invasive, biodegradable subacromial balloon spacer for the arthroscopic treatment of massive irreparable rotator cuff tears. InSpace is designed to restore the subacromial space without requiring sutures or fixation devices. Learn more at stryker.com/InSpace.
We are joined today by 2 outstanding guests. Dr. Sabrina Strickland is an associate professor of orthopedic surgery at Weill Cornell Medical School and an attending surgeon in a hospital for special surgery. She is an active member of many societies and research groups, including the International Cartilage Repair Society and the International Patellofemoral Study Group.
Dr. Seth Sherman is the director of the Sports Medicine Fellowship at Stanford University and is a team physician for Stanford football. He is the chairman of the AAOS Sports Medicine Arthroscopy Committee and is also a member of the International Patellofemoral Study Group with Dr. Strickland. Both Dr. Strickland and Dr. Sherman publish and lecture extensively on the topic of knee joint preservation, cartilage restoration, and specifically patellofemoral cartilage disease, so we're really excited to hear them speak more about this topic. So without further ado, let's get to the exhibit hall.
All right, Sabrina and Seth, thank you for joining us for this special episode of the Sports Docs Podcast at AOSSM annual meeting in DC. Welcome to the show.
Thank you for being here with us. So you both have published on and spoken a lot about patellofemoral cartilage disease. So Sabrina, you presented an ICL earlier today on, and we'll be moderating a topic tomorrow called Scratching the Surface Knee Cartilage Disease. Seth, you presented on when to add a derotation osteotomy and various techniques yesterday during the ISACOS session. So we're really excited to hear your take on this topic today.
Okay, so now this is a very big topic, as you know. So in the interest of time, we're going to narrow it a little bit to really dial down our conversation today to osteotomies. So for our listeners, we did a 2-part episode with Dr. Cassandra Lee. That was recently. She was tackling different cartilage restoration options for the patellofemoral joint, so we won't spend a lot of deep dive time there. And you can check that out. We'll post all that. And then a friend of the show, Matt Fury, is delivering my coffee.
Welcome to the show, Matt.
Thank you.
I'd like to think I was a good junior resident.
Yes. Former resident, junior resident of ours. Yeah. Thank you, Matt.
Our fellow.
Yes, right, exactly.
He's our fellow.
Oh my gosh, he's
awesome.
a great fellow.
Isn't he great? He was a great resident.
He was a great junior resident.
Yeah.
So.
Awesome.
Okay,
so today we're going to talk about osteotomy. So not every patellofemoral cartilage pathology requires an osteotomy, so when should we add one? So Sabrina, you published an article on arthroscopy last year looking at imaging assessments to guide decision making in terms of osteotomies. While this wasn't specifically focused on cartilage, it was focused on evaluating patellar position, which is applicable to osteotomy decisions. So in this thread, what are some reliable parameters that you're assessing on imaging to determine if a realignment osteotomy is needed?
I think we tried to make this way more complicated than it actually is. And so, my goal over the last couple of years is trying to simplify this topic, which I'm not sure we're doing the best job at. But first of all, if you just look at the patient's tracking and you look at a simple merchant view and you look at the AP, and if the patella is really sitting lateral, they need an osteotomy. I don't care what the TTTG is. If it's sitting lateral, it's tracking lateral, the wear is lateral, that's the no-brainer. Those are the easy ones.
And you mentioned let's keep it simple. Clinically, is there anything they're also saying to you or telling you that really helps, guide your decision, or is it really much more about the physical exam and the radiograph?
So, as far as deciding on an osteotomy, no. I mean, these patellofemoral cartilage patients typically come in with a very classic story. I mean, they come in, they say, they're not they're here today because they can't drive anymore, or they fly a lot for work, and that's becoming a problem. And everyone's complaining about stairs. Women are complaining they can't wear heels anymore. I mean, that classic story doesn't help determine whether or not you have an osteotomy, but it certainly points to the patellofemoral joint.
Yeah, first off, really excited to be here with you guys, and happy to be here with Sabrina. I was her resident at HSS back in the day, and she was one of the only people on or off the record who actually let me do some things in the operating room and listened to my suggestions. Didn't always agree with them, but listened. So thank you for that, and worked with us at the VA hospital.
Nice.
So it was awesome upbringing there. I think for this topic, it's obviously a passion of both of ours. These patients come in with those painful effusions, mechanical symptoms. They have swelling between their episodes of instability.
Yeah.
So that cues me into cartilage, and then cartilage clues me into unloading. So my biggest indication is to unload cartilage lesions, right? And that's typically with anteromedialization type osteotomy. My second main indication would be for patella height abnormalities, and that's with either J signs or apprehension deeper into flexion, and those patients are recurrent dislocators, and that's where the patella height's above a moving target threshold of like 1.4 for me, maybe lower for you.
Probably lower for me.
Yeah.
And when you start talking about patellar height is when you really got to drill down on the pictures, because you get a pretty good indication just based on X-ray. I typically get an MRI on any patient that I have any degree of suspicion for patella cartilage wear, and we tend to put these patients into two categories: dislocators or instability patients, and maybe maltrackers. But certainly we see a subset of these patients that actually have normal tracking, normal anatomy, and still have a cartilage lesion. And those are the patients where it's, I think, a lot more controversial whether or not they need an osteotomy.
Yeah, those patients are the ones that you're deciding whether to just anterize. And up till fairly recently, where Adam Yankee gave us the sagittal TTTG, we had no metrics by which to go on. So we can definitely measure patella height, we can measure lateralized force vectors, but we couldn't really measure posteriorization till previously.
Yeah, you published an editorial commentary on the sagittal TTTG. Can you tell us a bit more about that measurement?
So it took us a little while to learn how to do it. And so
thank you, Adam.
Exactly. And Drew Lansdowne has published a couple papers, and that was his paper that we were commenting on. But basically, if you're used to measuring TTTG, it's a very simple measurement, and you can kind of eyeball it as you just scroll up for your TTTG. If it's posterior, it's sort of something to maybe measure. If you're scrolling up just when you're measuring your TTTG from the front of the patellar tendon insertion at the tubercle, if you're scrolling up and it's anterior, I think you don't even have to bother measuring. It's not such a big issue. But at least how I was trained, the option for these patients was a McKay and a lot of skin issues, and we were told you have to anterize it by 2 centimeters, which is insane.
Yeah, most of my anteriorizations now are 8 to 10 millimeters maximum. A lot of them combined with medialization and or distalization, frankly. And, I've kind of used it. I think you and I have similar techniques. You may freehand a V-shaped wedge. I use a guide to do it. But I think that allows for a much easier, safer way to do an anteriorization than previous. Some of the published ones, that Brian Cole's biomechanics one, I mean, that's there's a lot of cuts. There's thin posterior cortex. Your screws go from the side. I mean, it just wasn't intuitive for me, and it was hard for me to bring that from training to practice, put it that way.
Yeah, I think you both bring up good points about techniques. The techniques can really vary, and I think there's been a lot of development in industry to make all these different sort of systems and guides, and they can sometimes feel a little like, are we over, doing this? So talk to us both. Sabrina, let's start with you about, how you've changed over time with your surgical technique and the evolution of you specifically.
So I basically started doing osteotomies freehand. So I've never used a guide. The only time I've ever used a guide is when I did a biomechanics study, and we were just trying to standardize it as much as possible. That being said, I've definitely changed over the years in a number of ways. So I tend to use a lot more allograft bone blocks. So I use Evans wedge from MTF. I can pick my size. So if I want to distalize 8 millimeters, pull out the 8 millimeter wedge. I think it's very reliable. It gives a good buttress. We did a biomechanics study, which is about to get published, showing how much stronger that was when you pulled it apart. I used to do a distal cut and move the distal, if I was distalizing, take a bone block distally and move it proximally. That gave, that led to a pretty big stress riser. Knock on wood, I never had a fracture, but I worried about it.
Sure.
Now I've gone to feathering them all so that there's a minimal defect distally. And so by doing some of these little tweaks, my complication rate is far lower than what's published, and we're about to publish our TTO distalization, or my TTO distalization group, and it's about 120, and I've had 2 delayed unions. So it's not, and no fractures. So
That's great.
You know, I think it's something you shouldn't take lightly, but I think if you look at some of the newer
There's
techniques.
some things that you can do.
Yeah.
And this is being published, accepted, or we're just... When do we get to see it?
Yeah.
Exactly.
You're hearing about it now.
Yeah.
I think my journey has been,
Yeah.
I guess, a bit different than that. I was a little sad leaving training that everyone's doing things differently, especially with TTOs. No 2 people were doing it the same.
Yeah.
And a lot of different freehand techniques, K-wires, saw, not saw, different configurations. So I just really wanted to rein in the space for myself and for my trainees, and that's why I levitated. Are we allowed to say industry names here?
You
or
are allowed to
nobody's
say-
getting CME on the road while they're listening to our podcast?
may
No,
say
but
industry, you may
I met
whatever you like.
Al Merchant, the great
Okay.
Al Merchant of the Merchant View. He lives in our area in Palo Alto now, so I have kind of like Tuesdays with Al, kind of Tuesdays with Maury type of thing over the last several years. And Al had been thinking about a different osteotomy technique for 30 plus years.
Okay.
And I kind of took that under, I was just looking for a technique at the time. I had a couple of catastrophic distalization issues, pulling it off and or a fracture from a fall. I reported, I think, at Anna that year, 12% complication, way different than my hinged AMZs. So I was just looking for something standard and something reproducible, precise, and that I could teach. And so the MD3T system, the multi-directional TTT, that Al designed is basically what I've used. Now I have 75 plus cases that we're continuing to try to report on, and similar, safety profile, getting rid of that distal dreaded black line step cut. I mean, principles are all the same. Keeping the periosteum, copious irrigation, proximal buttress, a little bit different with the rehab versus an AMZ. So I think we're speaking the same language, just got to it in 2 different ways.
Absolutely.
Yeah.
We did publish in Arthroscopy techniques, at least my distalization, and with video. So I think that I've been directing people there because I do think there's different ways to skin a cat.
Yeah, you're saying the same thing. Everything
Yeah.
you just listed off, like all the points, is in that
in
technique,
that article.
yeah, as well. So it seems like
I
those
read
are
it.
the real.
Yeah.
Those are
And
the critical points.
You guys may or may not know, when this all goes live, we put it out on YouTube and our social channels, and we include a lot of these graphics, like your infographic that we haven't touched on yet, but and also, Sabrina, your article, and it shows these types of things. So I think for people listening, it's nice to have that multimedia.
So that's a good segue. Let's talk
Go
about
ahead.
that infographic. So we actually spoke about it on our podcast episode with Cassandra Lee a little bit. But we want to talk about how you adjust your TTO. We talked about the ways to make it safer. How do you customize your TTO to address different pathology? So for a cartilage lesion that's lateral versus a panpatellar or central, how are you adjusting the TTO?
Yeah, I think that was a lot of fun to do, and to do it alongside one of my favorite mentors of all time, Jack Farr. He's taught me probably more about the patellofemoral joint than almost anyone except for Sabrina and a few others I'll put out there. But no, it's all, I think first point, it's all about cartilage mapping, when to do osteotomy alone and osteotomy plus cartilage. So that's key point number 1 to me. So if you have those lateral lesions Sabrina talked about with a high TTTG, you can offload those, you shift forces proximal and medial, and life's good. That's a classic Fulkerson 87% or better, right? Central, medial, panpatella, bipolar, totally different animal. He didn't get good results with just his osteotomy, so that's where you need a combined strategy. And so, I think the metrics for me would be the same as far as I don't obviously know people worry about over medializing. I'm just normalizing force vectors, and I'm going to take a TTTG above maybe even 15 for cartilage. I mean, so my threshold's lower. Instability will be higher than 20 in most cases, but it's more about the gestalt than the number. And I'll bring it down to 10 to 12, but probably even more important than that, as a last point, is intraoperative assessment. I'll do what Liza Arndt taught me and just take the knee from 0 to 90, and I'll make sure the patella tendon is just basically going straight down the middle at 90 degrees. She calls that the tibial tubercle sulcus angle, and if that's 0, you're not over medialized or under corrected. So hopefully those are some kind of pearls that took me a really long time to dial down.
That's what we aim for here, are those pearls. That's awesome.
Excellent.
Sabrina, same.
So I think a common question is, like, for example, a medial facet lesion. And we really were at a loss, like what we didn't want to medialize into a medial facet lesion. And we're assuming this is not a post-traumatic medial lesion, not from an instability. And so one thing we just looked up is we looked at all our medial facet lesions that either had a chondroplasty or a cartilage procedure and looked at their tubercle height or their sagittal TTTG, and it is significantly less. And so that's a population where you start thinking about just the straight anterization. The other thing, we were sort of taught, like, you never want to distalize somebody with a cartilage lesion because you're going to increase contact pressures. But what we've done is, at least over the past maybe 7 or 8 years, at HSS, I've 3D printed some of these abnormal knees, because one of the problems of using cadaver models is that they're normal, and these patients typically don't have normal anatomy. They're pretty much all dysplastic, and so by 3D printing them, we could look at the changes that we're making in contact pressures by anterizing the tubercle, medializing the tubercle, AMZs, and what we know is if we just increase the contact area, that's a win.
Okay.
Yeah, if you distalize, you don't want to over distalize those patients, but if you go from a 1.3 to a 1.1, you'll take force from the distal patella and you'll distribute it more broadly. And so it's counterintuitive to think that, if you made Baja, and they did that in one of the biomechanical studies, that sort of like brought confusion more than anything, and I think set us a little bit back, because I distalize for cartilage defects all the time as I do for instability, and I have not been burned by that strategy. I guess let me ask Sabrina about these lesions that you have no measurable malalignment parameters. Either you're going to anterize, or maybe you're going to just go to a structural cartilage, like just do an OCA. And for me, if I'm doing a cell-based, I'm more often than not finding a reason to osteotomize. Whereas if I'm doing a more structural, mature Highland construct, maybe I'm trying to get away with not doing it. I don't know if you feel the same.
No, I think I'm far more likely to use an OCA in a patient that doesn't have malalignment, because maybe they had some trauma that they don't remember when they were 14. They fell on this, the sidewalk. But I think that you're putting that cartilage into a hostile environment, and you may not know why it's hostile.
Yeah, I think one more point that came to mind. I kind of use trochlear dysplasia as a modifiable risk factor for a lot of things in patella instability. It's not that I'm always aggressively or over-aggressively treating it, but it's always the elephant in the room.
Right.
It's a risk for chondrosis. It's a risk factor for instability. And so if someone has that, I'll be more mindful to kind of do more around it, either treating cartilage and or fixing maltracking.
Specific to that, where you're talking about how you're treating the cartilage at the same time, how does that person's activity level play into that? So I think I would say New York, you're going to have very different sort of folks than you are in sort of, Bay Area or Colorado. You're still, you're having very active, healthy individuals, but it's different. Like, I don't have anyone ever coming into my clinic saying, I can't wear heels anymore. It just doesn't happen.
They can't climb mountains.
Yes, that's it. You know what I mean? So how does that sort of play?
Well, I think it plays a little bit just in that we know cell-based treatment takes longer. And so if I see a college student, I'm a little bit, it really depends. But first of all, I lay a lot more crepe. This is going to be a long time. You can't do it. If you do it, you're going to screw it up. If it's a patient that's slightly older, if I tend to go more OCA depending on what they, when they want to get back to activities. But again, we have lots of hikers, but not like you do.
Right. It's just different.
I think the question to me triggered immediately just goals, expectations, and communication, which is a huge part of knee joint preservation and osteotomy and cartilage, so in general. But I also tend to, I tempt natural history with a lot of staging scopes and chondroplasties and see how people do. And, I'm not always quick to put them in this group, because it's a long and potentially morbid road, and they really need to, have the problem, the percent normal, lower than 60%, pain levels 6 or more. You need marginal gains, I guess is my point.
And one thing, at least the way I was taught, and I don't know, Seth, if you felt this way, because I know your fellowship was different, but we were sort of taught, like, do the definitive operation. And one thing that was really great for me about Macy is that I had to do the chondroplasty first. And there are a number of these patients, and we know this now, it's been borne out in the data, that if you do a chondroplasty, they might just be just fine. And so, you know, it kind of forced me, and a lot of cartilage surgeons would just by default do a staging scope. It just wasn't how I was brought up. So it's taken me, I've had to shift a little bit, which I think has been good.
Yeah, I don't think philosophically I ever saw staging arthroscopy in my residency training, and certainly Brian Cole's philosophy and others was all about the staging arthroscopy and getting information, making a problem list, having a future plan, seeing how they do. The Rush Group just published on their CERT score, which we can kind of use to see which patients might go from biopsy to implant. That can be helpful to people, so you can counsel these patients. But, you know, I think we can, as surgeons, take over the natural history, and then it's on us, it's for better or worse, or we can let the natural history guide us, and the patient will come in saying, I do need that osteotomy. I need that cartilage. I'm ready.
I think that counseling piece is really important. When you are talking to people about, and we're obviously deviating a little bit from our osteotomy talk, but we do that. When you're thinking, okay, we're going to do our first stage, maybe we're taking cartilage biopsy, these type of things, what are you saying to the patient? How do you counsel them?
I think it really depends on the lesion. So if it's, I use the analogy pothole. If it's a huge pothole and it's a younger patient, I really tell them that I don't think it's appropriate to treat this conservatively. So we're doing a biopsy with the planned osteotomy with let's say it's a Macy. For smaller lesions or lesions that, depending on the location, like a medial facet or medial trochlea, I might be much less likely to recommend surgery. I would just say let's see how this does. Some patients are just fine.
So for me, I put a future plan in all of my operative reports, and I give the patient that operative report, and we go through it in detail, and I refer back to it every time I see them at 2 months, 3 months, whatever, so I can see right off very quickly what was the alignment, what was the meniscus status, what was the cartilage defect or defects, what was I thinking would be the future plan, and then I can just have a barometer of when we should enter that plan. So that helps me just kind of cut corners and really remember the patient very quickly, just from reference.
The only caveat I would say to that is sometimes with insurance approval, you have to be a little bit careful what you say exactly, because sometimes there may be a second lesion that you are planning on treating, but you want to underplay that a little bit, or if it's bipolar, you want to underplay that, and then it's sort of, but I agree. I have my staff print out my op note for the first year if I see a patient, just so that's the first thing I see, rather than logging into Epic and going through and finding my op note, because I do try to make that as clear as possible.
But I also do agree with Sabrina, when you have these young patients with focal defects in weight-bearing zones, their natural history is not good, and they have malalignment and a cartilage defect, a valgus active female with a defect or no meniscus. I mean, that's not someone we're sitting and waiting on.
What are we doing here? Yeah.
That's very different than if I had a knee scope and I have X, Y, or Z defects. You're waiting. We're waiting. And you're not touching my varus either.
Yeah. We'd like to.
For now.
Exactly. Well, you mentioned something that, again, is a little bit off the track, but I wanted to talk about. You talked about trochlear dysplasia. So I feel like that's kind of like a hot topic. How are you assessing that? And then are you addressing that surgically? What are your indications to do that, and what are you doing? It's like 8 questions in one.
Yeah.
Go.
Okay.
So one by one.
I think you get a tremendous amount of information from the lateral x-ray. So lateral x-ray gives, for PF, that's like the key to everything, right? The patella height. You can start understanding if there is trochlear dysplasia. Is it high grade or low grade? I think the rest is a lot of nuance. And then obviously we get axial imaging, MRIs on most everybody. I'll get 2D and 3D CTs. I can print them out and look at them if I really have issues understanding the shape. We're not quick to treat the dysplasia in primary and even sometimes secondary situations, so it's really a salvage for a lot of scenarios. But I think that it's my number one modifiable risk factor, as I said. If I was going to just do an MPFL, maybe I do an MPFL TTO, or other things like that, or rotational abnormalities. And then if you have that huge jumping J sign, you have a convex trochlea when you measure the height of the top of that mountaintop versus the anterior cortex of the femur, if that's more than 8 millimeters, that patella is going off a cliff and it's going into the gutter, and you can do whatever you want to it. It's not going to solve that problem. And if you do fix the tracking, in my opinion, you're still going to get the cartilage wear over time, because now it's just riding over that mountain in a very different way. So I've done maybe 1 1/4 trochleoplasties now. David DeJour gets referred them every day. He does 30 a year. So I mean, this is not a lot of trochleoplastying, right?
That's an interesting
We're in
stat.
our infancy of trochleoplasty, and he's in his like elder years of it, and still not doing more than like a couple a month, right?
Yeah.
What do you think? Teach me.
so far I've resisted the trochleoplasty, but I also tend to get patients, I think, a little bit farther along in a lot of cases, meaning they already have a significant cartilage pathology, and then it's essentially too late to do a trochleoplasty. I certainly have done a number of entryplasties where you're sort of, and I have a very low threshold in a patient with significant dysplasia to distalize them, because it's very common to see ALTA with trochlear dysplasia. I mean, it's when I'm explaining to patients, I'm like, this is how you sort of got the dysplasia, because your patella wasn't in the groove to form. But, I always think of the, sort of square peg in the round hole. If you change the shape of the trochlea, you're not changing the shape of the patella, unless you're David DeJour, and I think he has done some patellar osteotomies, which is scary as as can be. But I think you really do need to look at that lateral X-ray, and I think looking for trochlear dysplasia really can help for decision making.
A couple other points. You do a lot of PFJs. A PFJ is a trochleoplasty with metal, right? It takes a convex groove in an arthritic joint and makes it a concentric entrance for a trochlea. So that's one. A proximal OCA that's large is a trochleoplasty of sorts, right? You get that entrance flush. For some of these patients where you look on that lateral X-ray, you follow the anterior cortical line to where the crossing sign is. If that crossing sign is close to that anterior cortex and there's just a little bump sitting there, this entrance trochleoplasty or Lars Peterson grooveplasty is a very simple thing to do, combined with your MPFL, lateral lengthening, or both. And like, there's no morbidity to it in everything I've seen or done. Very different than when you're pulling the trigger on a full and formal deepening trochleoplasty as far as, risk categorization. So just things that I don't think we have teased out. Mary Havisi just reported on this recently, and we're trying to get a thinking group together to rein in entrance trochleoplasty versus trochleoplasty versus ignoring trochlea and working around it. We'll let you know how that goes. You have to have us back up.
We'll look
Might
out
have
for
to have
that.
a follow-up visit. So we've been mostly speaking about TTOs, but there's obviously other osteotomies around the knee to address patellofemoral pathology. So Seth, you presented on derotational distal femoral osteotomy, I believe was that yesterday. So tell us a little bit more about this procedure and who are your ideal candidates for it.
Yeah, I think in general, when you leave America and you go to ESCA or you go traveling fellowships, etc., it kind of opens your eyes to other ways to see the patellofemoral joint and other pathology, of course. So huge force vectors are on the patellofemoral joint from valgus, and huge force vectors are on the patellofemoral joint from femoral version and tibial torsion. And probably as big or bigger than some of the other ones that we're treating, all the time. And so that's kind of where the impetus came from, listening to Vicente Sanchez Alfonso, who does a ton of these in Spain, and his algorithm. Bob Taichi, obviously in America, has talked about this and done this forever, and a small group of his followers who have gone out into the world and do these routinely, or our college just wasn't familiar in our training, right? So I guess to jump forward, until one, you have to see the pathology. So you need to turn patients prone. You need to look at them standing. You need to get mechanical axis views. You need to get views of MRIs that have spot images at the hip and or CTs. So you got to do the work and measure. And measurements are inaccurate, and you need to measure different ways to make sure you're treating the right thing. And this is, again, for me, a super small and rare group, but it's a group for sure. And we wouldn't solve the problems with everything else we were just talking about. I wouldn't have been able to execute it until I learned about patient-specific instrumentation and measuring. And so now I have a tool to match my understanding, and that's where I think this has evolved for me over the last year or two, with using PSI to do things I never thought possible for my practice, like opening or closing wedge distal femur with derotation, and potentially treating the severe trochlear dysplasia, which is inherent to that syndromic patient.
I mean, I think in an ideal world, we'd get some of these patients before, while we can still alter their growth. So if you can somehow capture these 10, 11, 12-year-olds with guided growth and guide them away from their valgus, you may avoid this altogether. And I'm not a pediatric orthopedic surgeon. I sort of start taking care of patients around 12, and if they need guided growth, I involve one of my peds partners. But my best friend, I sent to Seth's coworker, because my best friend's daughter, and I mean, he saved her. Like, she's going to have a good knee because of guided growth. And so, I think more community awareness among our peds, pediatricians probably before even peds ortho, to try to prevent this valgus.
And I think
Avoid the problem before it exists.
Yeah, you're both sort of saying we also have to look for the problem. It's almost like those meniscal root tears where sort of eyes closed for a little while, and then you start to see them. You have to look, and it's you're sort of saying the same thing. Like, you actually have to look, do the exam right, do the imaging right.
And I think it's okay to recognize that you have a bit of an outlier aversion, but you're not going to treat it. You're going to do, maybe you're just going to roll your dice with a really well done MPFL they've never had, or do an MPFL plus TTO, because they do have some pathology there as well that you can correct. And so we're seeing version, torsion, trochlear dysplasia all the time. We're not treating it all the time, but it would be wrong not to recognize it and to know that it's in there as part of your risk factors. Sabrina and I are part of Jupiter, and we're partnering with them to try to machine learn a lot of this, because there's too many variables for our little brains to comprehend. We need someone to put in a computer to tell us what the relative risks are.
Like what you can correct and get away with, right? Like, I feel like there was a study, I don't remember which one it was, but looking at with trochlear dysplasia, you can do a TTO and MPFL, and you don't have to address the dysplasia, right? How much derotation do you really have to do? Can you get away with, as you said, an MPFL and TTO?
I mean, John Fulkerson spent his whole career not doing trochlear plasties, as have everyone else.
Exactly. So.
My dad tells me, what have I been missing it all these years? I'm like, no, you haven't. It's fine.
But Seth, you'd agree that it's the very rare patient that their first surgery is a derotational osteotomy. I'm not saying, I do see patients I just had a patient, and I am lucky enough to work with, I have a limb lengthening service at HSS. Wow. So these guys rotate and lengthen and do all sorts of things routinely. But often if you have to do a femoral rotational osteotomy, then you have to derotate the tibia, and it's a lot of surgery, and they don't look like a standard knee. It's hard to miss those cases that you're going to do that primarily.
Sure.
Think about it, but you don't necessarily have to treat it.
Awesome. Well, it sounds like a lot of exciting things coming down the pike. So we're looking forward to hearing.
We're going to have you back.
Yeah, we're going to have you both back on to give us an update in
Where's
a few
the
months
studio?
or a year.
Outside of AOS, is it?
You can go see Catherine in Denver or me in New Jersey. So
I
know
would say
it's a really
Denver.
tough choice.
That is tough.
Jersey
Sabrina, what do you
Colorado.
think? I am from Staten Island, so Jersey sounded pretty appealing.
I didn't know you were from Staten Island, so I grew up in New Jersey.
Yeah, I actually practiced where Catherine grew up.
Oh,
so
awesome.
It's like, it's crazy, small world.
Funny.
But thank you guys so much for
thank you.
being on with us today. This was awesome discussion. And I hope you enjoy the rest of your meeting.
Thanks so much
Thanks,
for having
guys.
me.
We feel really lucky to have you. Thank you. Thank you for listening to this episode of the Sports Talks. We hope you enjoyed the discussion as much as we did.
Make sure to subscribe on Apple, Spotify, or wherever you get your podcasts to stay up to date on all things sports medicine. Exciting announcement, we are also now on YouTube. You can find links to all of our social channels and our contact information on our website, www.thesportstalkspod.com. We love to hear from you.